Okay, hello everyone, and welcome to the 2020 to 2022 Hypertension Canada Guidelines and Beyond webinar. Why are we concerned? Thank you all for being here today. We appreciate your attendance. Just a couple housekeeping items before we get started today. We ask that all attendees remain on mute for the duration of the webinar. If you have any questions throughout the session for our webinar speaker, please feel free to direct your questions to the Q&A section of your Zoom dashboard. We will be holding most of the questions until the end of the session. At that point, we'll be answering them, but feel free to type in your questions as we proceed. Now, I'd like to hand it over to our speaker, Dr. Dresser. Over to you.
Great, thanks very much, Chanel. Yeah, thank you all for attending this, and I hope it's of good value to you. I know there's lots of things you could be doing on your lunch hour. I think with the number of people that we're expecting, it'd be best if we could sort of get all the questions in the chat box, and I'll try to work through them as best I can. I'm hoping I can leave enough time for a good question and answer period or comment period. And during that time, it's great if you want to unmute and say, you know, I've got a comment or a question or whatever. That would be absolutely fantastic from my perspective. So just some disclosures before we get started. I guess the main reason I'm here doing this with you is that I'm a member of the Hypertension Canada Recommendations Task Force. I chair the subcommittee that's responsible for making recommendations about drug therapy for what we're terming the uncomplicated patient without, a clear, compelling reason to give them one drug over another. I have received honoraria from a number of companies that make drugs that lower stroke risk, not just antihypertensives, but also anticoagulant medications, and I put the list there for you. This CME presentation was sponsored by Servier Canada, who market both Lixiana or Doxaban, as well as Viacorum or the amlodipine perindopril combination. The sponsorship was really, great. They left full editorial control over the content, so that I could sort of try to be creative and make it of good quality for you. The majority of these slides were actually developed by members of Hypertension Canada. They're based on peer-reviewed studies. Where something is just my opinion, I will try to make that clear to you. And I guess, probably my biggest disclosure is that I treat patients in Ontario with hypertension. I'm paid by the OHIP plan, and certainly some of my thoughts about it are definitely affected by the work that I do here and the type of practice that is supported by OHIP. So our objectives today are to talk about the recent changes in prevalence of hypertension in Canada. And for those of you that were fortunate enough to attend the annual meeting, I know you've probably seen some of this data already, but I think it's really important. And Canada has done so well managing hypertension, and it's a bit sad to see us slipping. And so I wanted to just mention that. Really, the main part of this talk is going to be to try to summarize, some key points, things that may have changed in the recent guidelines, but also to talk about what's still important and what I view as critical to the day-to-day management of the hypertensive patient. And then there's a few special topics that I thought we would throw in just to make this of high value for you. So to summarize the data, what we know about high blood pressure as a disease in Canadians, we think that about 1 in 4 adult Canadians are living with the diagnosis of hypertension. And what that means is that if those people are better managed, they can have a measurable reduction in the risk of strokes, heart failure, renal impairment, that sort of thing. Certainly from a billing perspective, hypertension dwarfs all other diagnoses in primary care. And then in terms of prescriptions that pharmacies end up processing, there are about 4 million prescriptions every month in Canada for antihypertensive drugs. And it's thought that the cost of hypertension care approaches about 10% of all healthcare spending. Now, with COVID, perhaps hypertension care is a slightly smaller proportion of the overall costs, but this pandemic is going to be over very soon. And so we'll be getting back into the regular care of our patients. And so about 10% of spending is thought to be spent on hypertension management. So this is the bad news in terms of what's been happening with prevalence rates. For the most part, they've been stable around 70%. But we know now that if we do a really great job of managing hypertension, we ought to be able to get rates up around 90%. But what's really concerning to me is that if you look at the control rates in women, it's actually gone down. And it's approaching 50%, which is really scary, and means that we're going to be seeing more hypertension related disease in women. And I'm not sure, I know, I attended some of the discussion about this. It's not clear to me why this has happened, but I think it does make me think that we need to do a better job of educating and also helping our patients effectively. So what I wanted to do just to start this out is to talk to you a little bit about the journey that a patient follows as they are identified with the condition called hypertension, and then as we start to manage them. So, it always starts with the identification of an elevated blood pressure in a patient. And as you know, an elevated blood pressure doesn't mean the patient has hypertension. It could mean that they were just in a car accident and they're scared. It could mean that they have pain. There are many reasons to have an elevated blood pressure. So, sometimes this is discovered in a pharmacy, sometimes it's discovered, in another clinic, for some other reason. But this leads then to a process that starts with the accurate evaluation of the blood pressure. So the first question is, if we see an elevated blood pressure, did we measure it properly? In association with the accurate evaluation of the blood pressure, we need to start thinking about what are the causes. Is it an environmental issue with too much salt? Is there some sort of organ problem? The kidneys aren't working. Are there genetic causes of hypertension that we need to consider? And this is very much an iterative process where we sort of go back and forth. And the first few visits with this patient are going to be really looking at these two key issues. Once we've done this, then this allows us to go on and start thinking about other aspects of care. So once you've identified that, yes, this patient definitely has hypertension, the next thing you need to do is try to evaluate this patient for end organ damage. So is there evidence of left ventricular hypertrophy on an ECG or an echocardiogram? Are there other changes on an ECG that are relevant? Has this patient had a stroke already? Has the patient started to develop chronic kidney disease or proteinuria as evidence that their blood pressure is damaging their system? If they have end organ damage, then obviously you're going to try a little bit, perhaps not harder, but you might try to initiate pharmacotherapy a bit sooner in the process. In addition to looking at end organ damage, you're also looking at the company that the hypertension keeps. So thinking about evaluating their global risk. So, is the patient participating in healthy activities? Does the patient have diabetes? What's their diet like? Are they smoking? How are their lipids? What's their family situation like? So we look at global risk as this part of the assessment. Once we have completed our evaluation of end organ damage and lipid, and other global risk evaluations, that then allows us to set thresholds for pharmacotherapy and targets. And all of those things then play in. Once we have the full clinical assessment of the patient, we've decided what the threshold for initiating pharmacotherapy is and what the target is. Then we start thinking about what are our pharmacotherapy options and how are we going to get this patient onto an effective complement of antihypertensive medications. And then I think one of the other things that we perhaps don't talk enough about is that hypertension is a chronic disease. And one of the most important aspects of managing a patient with hypertension is getting the follow-up plans right. So, how are we going to arrange for ongoing follow-up of the blood pressure itself? And how are we going to make sure the monitoring of blood pressure is done well? How often does a patient need lab work done? How often should we be asking a patient about drug side effects to try to make sure that we're really optimizing the benefit from the drugs? And then how often should we be reassessing for end organ damage? The whole point of pharmacotherapy is to prevent strokes. So how often do you need to have the patient back to say, have you had any stroke-like symptoms? Excuse me, I don't have COVID. Um, so that's the overall process. Now we're going to dig down a little bit and look at some of the specific issues that can be problematic. And I guess the first thing that I would say is that I need a commitment from everybody on this call to never do what is depicted in this picture. So what's wrong with this picture? Well, this patient is having a blood pressure measured while sitting with the legs dangling off the examining bench in a chair without a supportive back. So this is obviously not a good way to measure the blood pressure. And if your goal is to try to establish what the long-term risk is of having high blood pressure, this is absolutely the wrong thing to do. So, we need to try to use out of office blood pressure measurement techniques as our primary mode of both diagnosing the disorder and I think following up on the results. There's lots of data that suggests that out of office measurements correlate with future cardiovascular risk much better than the measurements that we would be conducting in a clinic setting. One of the problems with running a hypertension practice is that, I have a hypertension clinic that starts at 1 o'clock in the afternoon. Actually, I just did it yesterday. And, I'm not allowed to have the patients come in more than about 1:45. By the time we do a complete set of vitals, sitting, standing, both arms, and do a medication reconciliation, the first opportunity I have to get into the room with the patient is about 1:30. So I've already blown a half hour of nursing and clinic time before I even get to start having a conversation with my patient. And I have found that one of the most efficient ways that I can optimize my clinical practice in hypertension is to actually rely on the out of office measurements. I don't do this with the first consultative visit, but once a patient has been seen and they've been trained up on how to do out of office measurements, I now often will actually neglect or omit the clinic measurement of blood pressure because it doesn't correlate as well as what we get by getting good out of office measurements done. So this is the 2020 reference guideline around both ambulatory blood pressure monitoring as well as home blood pressure monitoring. ABPM is done with a validated oscillometric device. It's worn for a 24-hour period. And the measurements are taken at 20 to 30-minute intervals, certainly in the daytime. Sometimes to be nice to my patients, I set the nighttime measurements to once an hour, just so I don't disturb the sleep too much. But certainly this is the current preferred out of office measurement. And then home blood pressure monitoring is wonderful. It's a self-monitoring technique. It empowers the patient to be able to do a good job in their own healthcare. And the recommendation here is that we want measurements done at least twice a day for about 7 days prior to the clinic visit. I tell my patients with home monitoring that if they're feeling great and they're between visits and the only person that's ever going to look at the blood pressures is themselves, they don't need to routinely monitor. So this idea of doing a daily blood pressure measurement that nobody looks at except for them, I don't think is terribly helpful, especially if they're feeling well. If they're not feeling well and they have symptoms of either low or high blood pressure, then absolutely do it. But then call me as your treating physician and let me know if you're feeling unwell and you're noticing a high reading, or you're feeling unwell and you're noticing a particularly low reading. I want to hear about that between visits. And certainly as we get better electronic monitoring tools, then eventually my vision of the future is that I will be automatically notified if a patient is feeling unwell and is experiencing either an elevation or lowering of blood pressure that seems out of the ordinary. This is some further guidance around automated and home measurements that's available in the guidelines. But the bottom line is that an examining bench is not a good way to do it. I get a ton of referrals for patients who've been identified as being hypertensive while in hospital, often on the ortho ward after they've had a knee surgery and they've been infused with saline or something like that. And they've been extremely hypertensive throughout their stay. But the reality is that all the blood pressures were checked in a supine position. Nobody bothered to check the sitting pressures or the standing pressures. And really, if you want to do a great job in this business, you've got to do it this way. Proper measurements, properly positioned. So this is kind of the different measurement techniques that have been used. And the only reason I show this slide is that we do alter our numbers to account for the mode of measurement. So, with an office measurement where the nurse is actually doing it, 140/90 is considered kind of the threshold, certainly in a moderate risk patient. If you're doing ABPM or home blood pressure monitoring, we shave 5 points off the systolic and diastolic. And then if you're doing ABPM, it's really the daytime or awake blood pressures. Nighttime, you can actually go quite a bit lower. And if you're looking at the 24-hour average on ABPM, we shave 10 points off the systolic and the diastolic to try to identify that higher risk profile. This is another just pictorial, if you like, of the diagnostic algorithm. Again, highlighting the fact that patient comes in for a dedicated office visit. They haven't just been in a car accident, but you're getting a blood pressure over 180 over 110. You can go ahead and jump right ahead and say, you've got this disease. We need to get you treated right away. If they don't have a super elevated blood pressure, then you start considering the company that the blood pressure keeps. Do they have diabetes? What's the criteria there to help you identify hypertension? And then the use of the automated office blood pressure is highlighted. And then the importance of out of office measurement is highlighted in this infographic. Again, what are the initiation thresholds and then targets for blood pressure? This is a reiteration. It has not changed for 2020. But if you're in a low risk category, with our threshold for initiating is around 160 over 100, which is why when you see those pressures at 180 over 110, you can justify jumping right into pharmacotherapy in that setting. But otherwise, you're looking for pressures over 160 over 100 in the low risk patient. In the high risk sprint type patient, you're looking at systolic pressures over 130 for initiating. And then all others, it's 140. And then the targets, once you've made the decision to treat with pharmacotherapy, your target blood pressure is, whether you're low risk or moderate risk, 140 over 90. If you're a sprint high cardiovascular risk patient, your target is 120. And if you're diabetic, it's 130 over 80. So just very briefly, I don't want to dwell on this. I know most of you on the call probably know all about sprint, could probably teach me, but what was a high risk patient in the sprint trial? So it was somebody who had established clinical or subclinical cardiovascular disease. By subclinical, we mean they had a coronary calcium score that was very high, or they have, carotid plaque, that sort of thing, but it hasn't caused a major stroke or a major heart attack. Chronic kidney disease with a GFR between 20 and 60 was a reason for high risk status in that study. Otherwise, if you have to pull out your Framingham calculator, if you've got a risk over 15%, that was considered high. Age alone, age over 75, but otherwise a good risk profile would qualify you to be a good patient in the sprint trial. And just to highlight that there were real benefits to treatment of blood pressure in this study, getting the patient down to, actually they got them to 121 systolic, the way they were measuring the blood pressure in that trial. And the number needed to treat was very acceptable on a 1-year scale. There were real absolute risk reductions visible. The relative risk reductions for just blood pressure treatment compare very favorably with many of the things that we think about in cardiovascular risk management. And I would highlight that in the patients over the age of 75, the benefits were accentuated. In terms of what happens in these elderly patients over the age of 75, one of the arguments against more aggressive treatment of blood pressure in these patients is that if they're frail, then we may cause harm. But in fact, when you look at the benefit, according to frailty within the SPRINT trial, as is illustrated on this slide, the patients who were more frail actually benefited more from intensive treatment. So, frailty in and of itself was not a reason not to be treated. They did exclude elderly patients who were requiring daily nursing care. That was kind of their criteria for saying you're too sick to be in the trial. But if you're short of that, frailty in and of itself is not a reason to deny these patients effective blood pressure lowering. We often think that older patients are more susceptible to adverse events or effects of drug therapy, but the best data that we have, this is from a large systematic review, the data actually supports the concept that patients under the age of 65 have more adverse effects per amount of blood pressure lowering than patients over the age of 65. So you really can't use an argument saying, oh, I'm afraid of adverse effects in my patient, I'm not going to treat their blood pressure effectively, as a legitimate argument for denying the patients the benefit. Another area that is somewhat new and that you may be seeing some information about in the next little while is chronic kidney disease. This is the 2020 version of Hypertension Canada's recommendations for patients with non-diabetic chronic kidney disease. Obviously, if they're diabetic, then the diabetes target and threshold are relevant. But for non-diabetic chronic kidney disease, if a patient meets that SPRINT criteria, then our target is going to be like SPRINT, 120 systolic. There's good evidence in polycystic kidney disease that a very aggressive blood pressure lowering can be helpful to protect renal function. And so there, the systolic target is actually as low as 110. And then other patients who don't meet SPRINT criteria, so maybe their eGFR is 70 mils per minute. In that setting, the target is similar to the moderate risk category where we're aiming for 140 systolic. Now, I would highlight that you may be seeing some different information because KDIGO, which is a big organization from a number of countries, has just published their 2021 clinical practice guideline. And what they're suggesting in their guidelines is that patients with elevated blood pressure and chronic kidney disease, and actually with or without diabetes, be treated to a systolic blood pressure target of less than 120. And so they've taken the approach that rather than saying we're going to have slightly different targets, depending on the specific cause of the kidney disease, they've just taken a very sort of a lumping approach to say we're just going to go 120 across the board. So, I wanted to say a few comments about resistant hypertension. And I guess the first question that comes up is how do you end up with resistant hypertension, or how do you get to resistant hypertension? And really, resistant hypertension means it's been resistant to healthy behaviors on the part of the patient and to the drug therapy that we've provided to the patient. So where do we start with drug therapy? Well, this is the current recommendation. This was initiated in 2017. And basically, if you have a patient whose blood pressure is above target or actually above threshold, and they've been doing the healthy living thing, then the current guidelines would say, in the lack of a compelling reason to treat them, maybe heart failure or something like that, that you can use, any one of these agents, or you may want to consider using a single pill combination. Now, those of you that have heard me sort of do talks will know that I really like single pill combinations because I think they allow us to get to target blood pressure with fewer steps, fewer complications, both on our part as the healthcare provider, but also on the part of the patient. There is lots of evidence suggesting that you get fewer side effects if you use a lower dose of a combination of therapies than if you try to go with a bigger dose of one. There is lots of data suggesting that adherence to a single pill combination is better than giving, two separate medications together. And so that's important. There's data from Ross Feldman's STITCH trial that you get better blood pressure control rates. There is some good data from the Carrero study looking at reduced cardiovascular complication rates. And then in the HOPE-3 trial, they used a single pill combination and showed that in the hypertensive patients within that trial, that there was a real reduction in cardiovascular event rates. The other thing that I would say is that in the time of COVID, we need to do what we can to try to facilitate patient care without having them coming into a place where they're at risk of becoming infected with COVID. And so using a single pill combination is a very effective way to do this. And I would say that when I'm starting patients de novo on drug therapy, I will sometimes give them a relatively low dose. So for example, maybe your favorite drug is perindopril with indapamide. You might give them the 1.25 pill. And I would actually ask those patients to cut that tablet in half. Now, this is a point where I would say that's not, the product monograph does not say for that particular combination pill that it's okay to cut the tablet in half, but this is something that we did in the STITCH and STITCH-2 trials, and it seemed to work quite well. But start with a half tablet to make sure the patient doesn't get any first dose, hypotensive symptoms. One of the advantages of the amlodipine perindopril combination is that it actually comes in a very, very low starting dose that doesn't require you to cut it in half. But anyways, start with a very, very light dose. If a patient is doing good home blood pressure monitoring, then you could say after 2 weeks of taking that initial half dose, if your blood pressures are still above our target, you can go ahead and auto titrate up to the full tablet. You don't have to cut those tablets in half anymore, which will actually further simplify your life and make it easy for you. And then you have a patient on really effective drug therapy in a minimum number of steps. When I see the patient back at 3 months, often, if the patient's been steady on their, medium dose of the combo pill, then I can increase it to a higher dose, and I still have that nice combination available. Or I can choose to add on, for example, amlodipine if I started them with perindopril and indapamide. So it does give you some flexibility, and I think it does facilitate care, especially for patients that are willing to do home blood pressure monitoring. Having said that, if you want a very pragmatic, simple way of thinking about what drug to start, I think that RAS inhibitors are a great place to start pharmacotherapy. And basically, I favor generally ACE inhibitors. I think the body of evidence supporting their use is maybe slightly more favorable than with the angiotensin receptor blockers. But if I have a patient who has a high likelihood of cough, so they have a diagnosis of COPD, when they're in my clinic with me, they're already coughing, that sort of thing, then I may actually choose the ARB in that setting. But otherwise, I'm thinking about maybe starting with an ACE inhibitor. Step 2 is that I'm either going to add a thiazide-like diuretic, or I'm going to add a dihydropyridine calcium channel blocker. My decision-making around whether to go with the combination with the thiazide-like diuretic or the combination with the calcium channel blocker is based on 2 points of decision-making. The first is, what is the potassium level? And the second is, does the patient have or are they at risk for developing pedal edema? So if I have a patient who has a lot of pedal edema, I may be more likely to use a diuretic. If I have a patient who is at the lower end of a serum potassium level, I'm going to use the dihydropyridine calcium channel blocker. I would say that based on studies like Accomplish, I am more likely to use a calcium channel blocker. If all other things are equal and I can choose between them, I'm more likely to go with the CCB ACE inhibitor than I am the thiazide ACE inhibitor type combination. So that's step number 2. Step number 3 then is basically I am going to add on whichever drug I didn't start with. So let's say I'm on the ACE inhibitor side of this slide, and I went with the ACE CCB combination in step 2. When the patient comes back, if they still have a blood pressure that is above target, then I'm simply going to add on the diuretic, the thiazide-like diuretic treatment at that point. So by step 3, they're on that nice 3-drug cocktail, not necessarily at the higher doses of any one of them, at a middle dose of each of them. If I started with the ARB, maybe I went with the ARB diuretic for whatever reason, then I'm going to add the CCB. The patient will still end up on a combination of a renin blocking drug, a diuretic, and a calcium channel blocker. So that's step 3. So at this point, if you've got the patient on these 3 drugs and their blood pressure is still above target, that defines resistant hypertension. If you have a patient whose blood pressure is elevated and you haven't done this, then you don't have resistant hypertension. You just have the wrong selection of drug therapy. So do this, fix the first 3 steps. One of the things that you really need to do before you can say you have resistant hypertension is make sure the diuretic dose is at around 25 milligrams of hydrochlorothiazide or equivalent. So 2.5 of indapamide, probably 25 milligrams of chlorthalidone. And if you've got the patient on a good dose of diuretic, they're on their RAS blocker and their CCB, and the blood pressure is still above target, that's where you're into this resistant hypertension. So Hypertension Canada in 2020 guidelines saying that, it's high blood pressure despite 3 blood pressure lowering drugs. And we know these patients are at a high risk for adverse cardiovascular outcomes. And one of the things that was added in 2020 was that it's reasonable at this point, if you're starting to lose confidence, you're not sure what to do, it is very acceptable to consider a referral to a local hypertension specialist because they can help guide you beyond the decision making for those first 3 drugs, which it does get fairly complicated in terms of making one choice over another. And so this is a reasonable place to ask for help if you feel like you need it. And then just the comment on the therapy that I made earlier. There are a lot of strategies that you can consider in resistant hypertension. So the first thing is to take a step back now. You've gotten through this pharmacotherapy algorithm, but it's very reasonable when you recognize that you have resistant hypertension to go back and say, how much salt are you actually consuming? How much alcohol are you actually consuming? And do you have sleep apnea? What is your sleep quality like? And it's important to go back over that in an iterative fashion in patients whose blood pressures are not doing well. If you have, there's data from Kaiser Permanente that the first 3 drugs in their studies are associated with control rates as high as 90% approximately. And so if you have a patient that is uncontrolled despite that, it is reasonable to ask yourself whether the patient is actually taking the drugs as prescribed. What is their adherence like? And then obviously you want to try to eliminate other medications like NSAIDs or substances like alcohol, pseudoephedrine, caffeine, that sort of thing that may be interfering with blood pressure control. And then, this is where we start thinking about adding pharmacotherapy, and I'll run you through that. And then, a comment in the Hypertension Canada slide deck on, potentially a mineralocorticoid blocker, that sort of thing. But again, consider referral, consider primary hyperaldosteronism. It's more common than we think. Those patients do exceptionally well with spironolactone or Clarinone. And then consider other weird things. If the patient has weird symptoms, think about things like pheochromocytoma. But again, referral is not inappropriate. So, what is the best fourth drug? So this is basically the Pathway 2 study for those of you that care. But in my clinic, I have 3 options for what the fourth drug should be. And the area assigned to the drug that I have on the screen in front of you is really how interested I am in using that. So you'll notice that spironolactone is my preferred fourth drug. But in patients who are starting with a very high potassium level, that's where, above 4.5 kind of thing, that's where I'm thinking about using doxazosin or a beta blocker instead of spironolactone. And then in terms of whether to use the alpha blocker, doxazosin, or a beta blocker, I look at heart rate. If I have a patient whose heart rate is high, then the beta blocker becomes a more popular choice for the fourth drug. Whereas if the heart rate is low, that's where I'm going to consider using doxazosin. And you'll notice that, this is where we start getting into things like physiologic profiling with renin, and this is why you may want to make a referral to a hypertension expert. The bottom line is that after step 4, you've got a patient who will be on either, most commonly a RAS blocker, spironolactone, calcium channel blocker, and a diuretic. You may end up with a patient on, the first 3 drugs plus a beta blocker, or the first 3 drugs plus doxazosin. So what do you do if you've arrived at this point and the patient is still uncontrolled? So, the first 8 questions that you need to ask yourself if the patient's blood pressure is not controlled after the first 4 medications is the patient taking it? When I get referrals like this in my practice, one of the things that I sometimes do is have the patient bring the first 4 drugs to my clinic, and I hook up an ambulatory blood pressure monitor. I watch them swallow their tablets, and then I just let them hang out. And often what I find is that the pills seem to work much better when I observe the patient swallowing them than when the patient is, if you like, free range at home doing their own thing. There are many strategies that you can use to try to help with patient adherence. And I guess what I would say here is that, if you want to take a minute and look at this, this is from the 2020 guidelines, but really this is an individual thing, and it varies depending on who you are as a healthcare provider and also who your patient is. So there are no one solution fits all. But you can see some of the suggestions here. Obviously trying to make it easier for patients to take their pills, trying to simplify, use once daily dosing, using single pill combos, using blister packing, recruiting help of others. So, family members, other healthcare providers. And then I think, some patients respond to seeing when they do their home blood pressure monitoring, they see the blood pressure really coming down when they take their medications. That can be quite motivating. But again, I think that there are many tools and tricks. And I think, over the next 10 years, I would predict that we're going to be seeing more electronic aids to helping us improve adherence and just overall management of hypertension. If you've done all those things and everything, is as good as it can get and you're still in trouble, then just for those of you who care, the next step that I generally do is give more diuretic, because ultimately, if you give enough diuretic, the blood pressure will come down, unless the patient has Cushell syndrome, in which case that might not work. But Cushell syndrome is like 1 in 10 million or something. So you should be okay. And sometimes you just need more diuretic. The next thing I'd like to say is, what do we think about follow-up for patients? And again, I would say that there is no randomized controlled trial of high quality that I am aware of that tells me that any one monitoring interval is better than any other. So this is again an area where you as the healthcare provider need to practice the art of medicine and really adapt the follow-up planning to both your own practice setting, but also the patient that you're seeing. So in a patient who's low risk, they have maybe they have white coat hypertension, for example, and you've established that they don't have target organ damage, and you're not even sure about the hypertension. What I tell those patients is that the fact that you have white coat hypertension now means that in 5 or 10 years, there's a higher likelihood that you will end up with sustained hypertension and actually require management. And so even if I tell you I don't need to treat you for your white coat hypertension, you do need to have this reassessed at least once a year. In patients who are, making changes in their life, I think how often I follow those patients depends on whether they're symptomatic or not. So if they're very symptomatic, then, even every 1 to 2 months might be reasonable. If they're doing quite well, then every 3 to 6 months might be reasonable to kind of make sure that they're continuing these healthy behaviors. If a patient is on drug therapy, immediately after you start the drug therapy, you need to be making a plan, depending on which drug it is, about when you want to see them again. I tell especially diuretics probably take the longest to really kick in. And so I tell many patients where I'm starting them on a diuretic that it's going to take 2 to 3 weeks for them to really see the benefit of the diuretic therapy. And that, I don't want them checking their blood pressure the next day and saying, oh, this drug doesn't work because I checked my blood pressure and it wasn't any lower. If you're feeling fine, I tell them to wait about 2 to 3 weeks, then do a series of checks to see how good the blood pressure got. And then I may see those patients anywhere from, every 2 months to 6 months. And then obviously, how often you see a patient will also be determined by how high the blood pressure is. So just a couple of other points about care delivery, just to end. And I guess, this is a slide from the Hypertension Canada slide deck. I think, e-health interventions are going to be a tool that we can really utilize to help improve our patients' well-being. Obviously, you need a tech-savvy patient if you're using a technology solution. But I think part of our role in the healthcare system may end up being to train our patients to really use these technological tools well. Health behavior change is important, and there's lots of good support for that. We know that health behavior change is necessary in patients who have hypertension, just even learning how to take your medications. There is recommendations that actually one of the things I often do, if I have a patient who I'm really struggling with for their blood pressure, that's where I often look for other things that I can do to lower their overall risk. And so, thinking about what is their lipid level, and can I initiate or increase their statin to try to get them some cardiovascular benefit. We are now no longer recommending, and this is a new thing in the latest version of the guidelines, that for patients who are clearly primary prevention, we don't recommend the aspirin just because they have hypertension. They need to have another reason for that. So that's one of the other updates. So statin therapy, if a patient is smoking, then try very hard to get them to modify that. Try to move them through the stages of change with their tobacco use. And then in terms of healthy behaviors, just this is mainly what's still important. And then the alcohol recommendation is a new thing. So we're still recommending 30 to 60 minutes of moderate intensity dynamic exercise, 4 to 7 days a week. You don't have to kill yourself. And part of the reason I think high intensity exercise is not effective is that if you hurt yourself exercising, you are far less likely to keep exercising in any format. And so I think one of the most important things we need to tell our patients is injury prevention is by far and away the most important thing in exercise programs. And then the second thing is that they need to still feel good after they've exercised for the rest of that day, because if they don't, they're not going to keep doing it. Um, Another important point, some patients, have certain ideas about resistance training. The only patients I tell not to do resistance training are patients with aortic dissections. But if you haven't recently had an aortic dissection, then resistance training is great. There's good evidence that you can get a lowering of blood pressure even with resistance training. Maintaining a healthy weight is still in the guidelines. And obviously, I tell my patients not to worry so much about what their weight is, but to worry about living the healthy life that will allow their weight to follow what their healthy living is doing. And usually that means that their weight is going to go down. But I think this idea of becoming fixated on a weight is a recipe for frustration, because weight changes very slowly. It's not something that you really have agency over. What you have agency over is how you eat on a day-to-day basis. And so we need to be focusing on the things that we can change on the day-to-day and allowing the weight to do what it should do naturally. One of the new things in 2020 is a very explicit statement that in healthy adults, abstaining from alcohol, or at least reducing it to less than 2 drinks per day, is recommended to prevent hypertension. And I think also I would add to control hypertension. One of the most interesting things that I've seen over the last number of years in my clinic is that I can pick out patients who are very silent on alcohol intake. I can usually identify when they're drinking more than they should on the basis of their blood pressure becoming uncontrolled. There's a very direct correlation in many patients. In terms of other points on healthy behavior, again, the DASH diet is recommended. Even the current version of the Canada Food Guide is great. Sodium less than 2,000 milligrams. There's no systematic data suggesting that calcium and magnesium supplementation are necessary. If there is data that increasing potassium intake, as long as the patient isn't at risk for hyperkalemia, can reduce blood pressure. And then there's a recommendation for stress management as well. The final thing I'm going to say is that along the thought process of what else can I do to manage cardiovascular risk, I would say that there are many things that correlate with an increase in risk. And one of the things that I see in my patients that is quite common is the co-segregation of atrial fibrillation and hypertension. And one of the reasons that those things are co-segregated, if you like, is that obstructive sleep apnea can be, the etiologic factor that causes both the atrial fibrillation and the hypertension. And one of the reasons I want to bring this up is that this is another place where therapeutic complexity needs to be carefully managed. There's no question that age is the biggest driver of risk for atrial fibrillation, and it's the biggest driver for hypertension, as you can see from these slides. And so it's natural to believe that these two things would happen together. And interestingly, with AFib and hypertension, if you carefully manage hypertension, you can actually delay the onset of atrial fibrillation. If you carefully manage obstructive sleep apnea, you can improve blood pressure, you can delay the onset of atrial fibrillation. If you have a patient with AFib where you've decided to give them an anticoagulant, careful hypertension management can reduce the risk of them having significant bleeding events. And so this would be an area where you want to try to keep things very, very simple. You might be thinking more about using single pill combination therapy and some of the other tools that we have to improve adherence. And sometimes in a patient with hypertension, the most effective way of lowering their stroke risk is not to increase their antihypertensive therapy, but to give them an anticoagulant because they have AFib. The final thing I'm going to say before our question period is that it's worthwhile thinking about the pandemic in relation to how we manage hypertension. I think training your patients on home blood pressure monitoring is very important, both for diagnostic purposes as well as drug titration. Using single pill combinations, no question, it'll help you limit the number of clinic and pharmacy visits. And like I said earlier, I really like the strategy of a single pill combo half tab with monitoring by the patient. And then they can either call me and up titrate themselves, or they can just auto up titrate and then give me a call a couple of weeks after they've auto titrated to let me know how things are going. And there are other considerations that you may want to make. If you have the choice of initiating a drug that requires blood work to be checked, like their kidney function lights, versus a drug like a calcium channel blocker where that's not necessary, it's okay to go to the CCB because you are not going to have to do blood work and you don't want to expose that patient to the lab. The other thing that I think about is that if I can give a patient a drug that does not cause hypoglycemia, like a sulfonylurea, and give them a euglycemic drug like an SGLT2, I might be more likely to do that. And then another example would be patients on warfarin who require INR monitoring, maybe switch them to a NOAC in order to limit the need for regular lab visits. Finally, I would say if you're not already a member of Hypertension Canada, I would highly recommend it. There are great resources there. And I really think that, I hope that some of you are primary care practitioners, because I think that, effective management of hypertension really requires excellent primary care. Specialists can be helpful, especially in those complicated resistant hypertension patients. But I think, we need a good cohort, a core of primary care providers who are interested in really doing a fantastic job of hypertension management. And I think the future of our society is going to be in making sure that we do a great job at the primary care level. There are lots of good content on the website for both patients and providers. So with that, I am going to stop sharing, and maybe we can have some question and answer time. So Chanel, I don't know, do you want to kind of take a look at the questions, or do you want me to go ahead and do that? All right.
Sure. Yeah. Do you want me to read them out to you?
I
can.
Well, okay, actually, so I'm in the chat box here. So would you be able to share the recording? So that's a question for Chanel. Is the recording going to be available?
Yes, so the recording will be emailed to all attendees after the event, so that will be accessible to you, and you can watch it as many times as you like.
Perfect. Okay. So there's a question: has there been a quantitative assessment of the impact of caffeine intake? And is there a recommendation for upper daily caffeine limits? So caffeine is interesting. I've done some actually kind of granular research where we've looked specifically at that issue. And I would say that the biggest problem is in patients who do not routinely consume caffeine. So they have not developed tachyphylaxis to the caffeine and then get it sporadically. In that setting, you can see an increase in blood pressure of 10 points. And I think in my study with kind of healthier people, we may even have seen levels higher than that, up to 15 millimeters of mercury. It's a relatively transient effect, but where it really messes you up is in the monitoring, because if you have a patient who some days has a coffee and then checks their blood pressure after their coffee, they're going to get a much higher reading than other days. And some of the reason for variability on home recording may be related to caffeine. If you look at patients who are habitual caffeine consumers, then caffeine actually has very little impact on blood pressure control. And so what I tell my patients is you need to sort of make a commitment one way or another. If you're going to use it, I still recommend using it moderately, like, no more than 2 Tim Hortons mediums per day kind of thing. But yeah, that's the data that I'm aware of. All right. So another comment: I respect the findings of SPRINT, but how do we reconcile the findings of trials like SPS3 done for stroke secondary prevention, where there wasn't a benefit of getting down to lower? And do you think the large number needed to treat for SPRINT is a barrier that's resulting in less practitioners being aggressive? So I actually don't think the number needed to treat is that low. I would say first in the group that were over 75. For the 3-year trial, the number needed to treat was about 40 individuals over over 3 years. And there are a lot of other sillier things that we have done with an absolute risk reduction of 1%. So, just as an example, when we switched from using streptokinase and MIs to TPA, there was less than 1%, absolute difference in outcomes. And yet, there was everybody switched over to using it. So a 1% absolute difference is actually, significant enough. Again, I think it depends on the patient, and I have some patients where their risk profile really isn't that high. I also think that it is determined by, how much work is going to be involved. If I see a patient where I'm going to have to see them every week, if I have any hope of getting them to, a sprint level target, I may be less interested in that compared to a patient where I'm pretty confident that with every 3-month visits, I can probably do it. One of the interesting findings from both the Accord study as well as Sprint was that the patients who benefited most from the really tight blood pressure control were those who were starting not too high. So if your initial blood pressure is between 130 and 140, then getting you down to about 120 is very helpful. If you look at the patients that started at 160, those patients didn't actually get the same kind of benefit from a level of 120. And so I think the other consideration that I make is that if I have a patient at 160, I'm not going to aim for 120. If I have 160, I might aim for 140 over the course of a year or two. Once I have them at sort of in that 130 to 140 range, then I may have a conversation with them and say, listen, there is some data suggesting that if we could get you down lower, that you might get further benefit. But I'm also thinking about the other aspects of their care. So if they have diabetes, I'm thinking about, what are their diabetic strategies? I'm thinking about dual pathway inhibition with, for vascular disease. I'm thinking about some of the new lipid therapies. There are many ways to manage residual cardiovascular risk, and aiming for that sprint level blood pressure target is only one of them. And I'm generally, I kind of follow the path of least resistance. I try to improve their risk profile, but sometimes that's not necessarily by lowering the blood pressure. Okay, so all right, any recommendations on a blood pressure machine? So what I would say there is go to the Hypertension Canada website. Right off the front page, there's a link to a number of devices that have been looked at by Hypertension Canada and seem to work quite well. I often tell my patients to go to Costco, in London here, but most pharmacies have units that are very similar to the Costco one for about the same price. And I tell my patients to wait for Christmas or their birthday, and I tell them how wonderful it is for them to have a gift like a blood pressure monitor from the person who cares about their health. Okay, for chronic AFib, how do they do home blood pressure monitoring? Right, so the home blood, obviously with the variability in the R to R interval with AFib, sometimes it's difficult to detect the blood pressure. Most blood pressure monitors are designed so that you need to be able to lay the waveform over itself about 3 times before it'll actually kind of spit out the numbers. And so if you have a really variable R to R interval, the device may error out. Now, having said that, if your device gives you a reading, most of them are set up now so that if it gives you a reading, it's probably accurate. It's just the problem is sometimes they error and you don't get a reading. But if you're getting, I tell my patients, if you can get a reading off it, it's probably fairly reliable. I do have some patients where the only way I can figure it out is by doing it manually, despite my comments about not doing it manually. Life Brand, oh, here's a comment. Life Brand from Shoppers has a lifetime warranty on the blood pressure monitors. So yeah, so that's great. I mean, if you have a patient that plans to live for a longer period of time, then you could do that for sure. Now I'm going to switch over to the Q&A box. How often should we be calibrating or changing our office BP monitors? So again, what I would say on that point is that most of them are now designed, the circuitry in them, if it detects a problem. So if it detects a leak, for example, which is one of the more common reasons that older monitors would stop working, it actually is designed not to give you an answer. It'll give you an error code as opposed to an answer. So I think first thing I would say is if it's giving you numbers and it looks reasonable, then you probably don't need to be doing anything. With the newer machines, they don't tend to require a whole lot of calibrating. But you know, I never want to be left without any way to measure blood pressure. And so I probably buy a new device about every, I don't know, 2-3 years, and then retire the oldest devices, which are probably 15 years old. And when you bring the new one in, you can kind of compare it to some of the other ones when you're doing the measurements to make sure they're still working okay. Okay, acceptable difference between home BP and office monitor. What would be the ideal approach if there's a significant difference? Yeah, so I guess what I do is I have the patient bring their home monitor in. And if you slap their monitor on one arm, yours on the other, blow them up at the same time, let them come down, get that reading, and then cross them over. If they're fairly close in the clinic setting, pressure may be higher, but they're equal when the patient is using their home monitor in your office, then you can trust that the numbers that they're getting on their home monitor when they're at home are probably accurate. And in that setting, if there's a discrepancy where my office readings are higher, I ignore my office readings completely and I go with their home readings. When it's a different scenario from that, it really depends on the scenario. But in general, I tell my patients, I trust your home measurements as long as you're doing them right. I trust them more than the numbers that we do. Okay, so another question, what about aspirin for primary prevention in patients with diabetes and hypertension? So the Papadad trial was a diabetic trial, did not show the benefit of aspirin in primary prevention. And actually, they weren't really primary prevention patients. They actually had some vascular disease. So I think the presence of diabetes on its own doesn't justify aspirin therapy. The presence of hypertension by itself doesn't justify aspirin therapy. But I think there are cases where you may find that a diabetic patient with hypertension, even though they do not have overt confirmed vascular disease, may benefit from hypertension. The tool that I've been using actually in that setting where I'm wondering if there may be a benefit is a tool that was designed in New Zealand. And if you type in, I think it's primary care aspirin calculator and look for the New Zealand link, there is one there that kind of gives you an estimate of how many bleeds you will cause versus how many vascular events you will prevent. And you can kind of see the logic there of like the reason that we don't recommend it routinely is that we're actually causing a fair number of bleeds. But you can, within the individual, you can kind of give them a sense of what they're living with. But it is an interesting comment. Okay. Thank you for the review of the important information. Will the 2022 guidelines have more emphasis on screening for primary aldosteronism? So I think, you know, I don't know exactly what the wording is going to be, but I think a primary hyperaldosteronism continues to be a significant driver of resistant hypertension. And I think that screening for it is reasonable. There are some caveats around screening depending on which drug the patient's taking. And generally, if you're thinking about adding spironolactone in a resistant patient, you may want to measure their renin level and their aldosterone level before you initiate the spironolactone. But I don't know exactly what the wording is going to be on the rec. Okay, is there a way we can get a copy of the webinar to rewatch with colleagues? So I believe the answer to that is yes, from what Chanel mentioned. As an international medical student, can you please touch base on the stages and types of hypertension in Canada? So again, I mean, I would say that probably 80% of hypertension is primary hypertension, where it's really genetically mediated, and then on top of poor health choices, poor health lifestyle, behavior, not getting enough exercise, eating too much salt, not enough potassium. But probably 10-15% is hyperaldosteronism. Okay, another comment. I've been trying to have patients home monitor with 2 measurements, BID for 7 days, discard the first measurement, send me the average. They send me raw data. Yeah, so, actually, I think the raw data isn't necessarily a bad thing. When I get those raw data things, what I like to look for is I look for what's the lowest pressures what's the highest pressures, and then I kind of eyeball the average. Um, the Because, well, and then the other thing is that if they actually give you, like I tell my patients to measure, if you do a first one and a second one and they're more than 5 points different, with the second one being lower, then I tell them to do a third. And so you end up sometimes with these large sheets of, 3 measurements. But it is interesting to look at that, because if you have patients with where the first measurement is always significantly higher, that patient will have white coat hypertension. And then if you're doing an office measurement, that you really need to chill them out in the room, and really do a series of measurements well. I actually find it interesting looking at raw data. But again, I think that hopefully there will be some technology solutions for that, where hopefully there'll be an app and they can put it in their app. Maybe this would be a good thing for Hypertension Canada to build, is something where the patient can download the app, put in their numbers, and then spit it off or email it to you or something like that. Can the slides be available with the recording? So I'm happy to make a PDF of my slides and send it to anybody that wants it. I don't know, Chanel, if that's something that is possible, but we can certainly do that. Okay. If labs are not available, like the renal function tests and other things, how can you choose drugs for the patient? So I do think that, I think that the standard of care for helping patients with hypertension really is to be able to check renal function testing, for sure. And I think being able to check their potassium level really needs to, you need to be able to do that in order to do this well. Otherwise, it's difficult to know what you're doing with renin inhibitors, like ACE inhibitors. It's difficult to know what you're doing with diuretics. I would say that if you are interested in building a program of treatment, you need good support from a lab for that basic chemistry testing. I think an investment in that probably will more than pay for itself in terms of getting better outcomes for your patients. I think that you also need to be able to check renal function when you're evaluating what the cause of the hypertension is. So I really think that you need access to that. At what dosage level do you make a decision to add a second drug? So I go for half. So with amlodipine, if I'm at 5 milligrams of amlodipine, I'm going to go on to the next. With perindopril, if they're at 4, I'm going to go to the next drug. With ramipril, if I was at 5, I would go to the next drug. If I'm with, I don't know, telmisartan, I would, at 40, I'd probably consider adding another drug. So really, I go for half dosing before adding on. So use of thiazide in a patient with gout. So again, I think that this is this is actually an example where my first 2 drugs in a patient with significant gout are going to be the ACE inhibitor and the calcium channel blocker. If I've got them on, and in that setting where I'm a bit reluctant to start with the thiazide, I might actually escalate the doses of those first 2 drugs a little bit before having to add the thiazide. But if I've got a patient on a good dose of an ACE and a CCB and they're still hypertensive, if their gout is really well controlled, I will still consider adding in a small dose of diuretic, because the benefits from a hypertension standpoint can be quite profound. And then obviously I'm going to be aggressive about managing the gout. But I have patients where I've actually intentionally started them on allopurinol to suppress the gout so that I can get them onto a thiazide type diuretic. Okay, another question about reliability of home blood pressure machines. And I would just say, from that point of view, go to the Hypertension Canada website, take a look. Most of the devices that we have available are reasonably good now. The algorithms are working, and they seem to work fairly well. Timing of medication use, yeah. So 2 things. Most important thing about timing medication use is I tell my patients with hypertension to take their pills when they are most likely to remember to take them. That's by far and away the most important thing. If they say, "Doc, I'm such a great patient that I can take my pills whenever you say," I tend to like to give my ACEs, ARBs, CCBs at nighttime. And I like to give my diuretics in the morning. If you use a very long acting diuretic like chlorthalidone, you can actually dose that any time of day, and it doesn't seem to matter. I have a number of patients that take their chlorthalidone at bedtime because they're taking one dose per day, and they take it all at nighttime, and it doesn't make them pass more urine through the nighttime hours because it has such a long half-life. And obviously, if the peak level of the drug is overnight, and generally, even with once daily dosing drugs, except chlorthalidone, where there's really not much of a peak trough effect, with most of those other drugs, the peak drug level, and therefore the highest likelihood of dizziness, is going to happen in that sort of 4 to 6 hour range. And so hopefully the patient will be lying down sleeping when they're at that point, and that should minimize the dizziness. So it is now 10 after 1. And for those of you that stuck it out, thanks so much. And I hope this was useful to you. Yeah, just hopefully we'll have a chance to do something again in the future. Thanks again.
Thank you so much, George, for a wonderful presentation. It was so informative. I think we're going to have to do this again. There was so many questions, and I think the feedback has been great so far. So again, thank you again. As for the slide set, if you want to share it with me, I can definitely send it out to all of our attendees along with the recording, and everyone can look out for that. I'm going to end the webinar now. Okay, take care. Thank you. Bye.
Thanks.